institution by shaping me towards my further progress in my life. So, and I would like to thank the organizers for this opportunity. So, diabetic ketoacidosis. Basically, I will be dealing, not into the depth. So, I will be giving few concepts so that the individualized treatment can be managed by on your own. So, most of the guidelines they will give for the general oral pediatric admissions, but the child needs a individual care most of the time, because the onset of symptoms, duration, the severity will be varying from mild to severe. So based on that, you need to change the protocol according to the child's need. So the presentation itself, the DKA presentation in type 1 diabetes as the initial presentation we'll see in Indian scenarios up to 80 to 85% of the times. So most of our children, they will present with the DKA. That's very unfortunate. Compared with the Western population, only 15 to 75%, that depends on the regions. So they will be presenting as a DKA. And most of the patients also earlierly catched by the symptoms and regular screening. But due to lack of awareness, we'll be catching little later while after onset of the DKA. And overall of all the DKA episodes, 60% of the episodes are occurring in 5% of the type 1 diabetes. That means a lot of children, they're mostly following the poor diet or most needle phobia, they're omitting the insulins, and this is causing a lot of trouble and keep on recurring this DKA in the 5% of the type 1 diabetic patients. So these are the patients you need to be put more efforts and time to educate them and to prevent the future DKA episodes. This is the latest summary from the previous older guidelines. So there are few changes from older guidelines to the 2022 guidelines of ISPAN. The major change is the bicarbonate cutoff they have brought up to from 15 to 18, and the initial fluid bolus, because all the DKA patients will be having some amount of dehydration. The first therapy is the IV fluid, that is a normal saline bolus. So previously we advocate the bolus over the 1 hour, now we are advocating it over the 20 to 30 minutes. That's the change from the 2022. And previously they advocate that there is a slow rise in the serum sodium concentration we need to focus on, but nowadays we need not worry about the sodium rise. So we need not monitor the sodium frequently. And another important update is the co-occurrence of the hyperglycemic hyperosmolar state. So most of the time, both conditions are different. Both are emergencies, endocrine emergencies due to hyperglycemia. But pathophysiology is different for DKA and the HHS. So at DKA, the most common problem is the more occurrence of the ketosis, acidosis. In HHS state, the problem is the polyuria and associated dyslipidemia and very high levels of the glucose. So there is a lot of the time there is a mixed presentation of this DKA with HHS you need to be aware of, because both the conditions require a different approach, treatment approaches. Where in DKA will be mostly focusing on suppressing of the acidosis. In HHS, mostly we will be focusing on the correction of the dehydration and electrolytes. So the diagnosis, most of the time the children may not be having the symptoms like polyuria, polydipsia. I remember a case from the Nilofer, but when I was in first year, so most of the time they will be diagnosed elsewhere and comes to Nilofer. The diagnosing and sometimes the referral comes from the peripheries like a lower respiratory tract infection. So we will be thinking in that line. So we don't have a protocol at that time as a regular monitoring of the GRBS. So the child came in a shock with a low, something like shortness of the breath, a lower respiratory tract infection like scenario. Severe dehydration the child is having. But when we are cannulating the patient, we are trying to resuscitate the patient. So the child is passing the urine despite having the severe dehydration. So that is one of the flu indications that the child is actually having hyperosmolar status. That is there is a chance for the DKA. Then we tested, the GRBS was showing around 300 and 300 and above. So that is one of the clinical clues. So despite the dehydration, there will be polyuria and polydipsia. And one other important presentation of DKA is sometimes most of the time they will be having acute abdomen, mostly due to acidosis. There will be acute abdominal pain and vomiting, but never a diarrhea. So that is also one of the important clue. So child is vomiting and abdominal pain, not having a diarrhea and dehydration, then you should think of the DKA condition. But as a routine protocol, I think nowadays GRBS is a mandatory for all the ER rooms. Now everyone is doing a GRBS screening for all the patients. So DKA means D is diabetes, that is random sugar levels at least more than 200, and K means ketosis, that is urinary ketones is positive. If blood test for the ketones are available, then that will be good. And A is the acidosis, that will be measured by the ABG. So anything pH less than 7.3 with the urine ketosis 3 plus or 4 plus, which is important. Because 1 plus, 2 plus can be seen in starvation and other conditions, but 3 plus, 4 plus is more diagnostic of the DKA. If blood ketone levels are available more than 3 millimoles, that is diagnostic of the DKA. The hyperglycemia, so cutoff as around 200, and one thing you need to keep in mind is the euglycemic DKA, especially in little older patients, little adolescent patients and type 2 diabetes patients with the DKA. So where there is a history of SGLT inhibitor, alcohol, starvation, sometimes that will cause a euglycemic DKA. But in children, most of the time it is a hyperglycemic DKA. And based on the initial pH, we'll be categorizing the child to mild, moderate, and severe. So pH less than 7.3, that is a mild, and less than 7.2 moderate, less than 7.1, that is a severe. Based on the bicarbonate, less than 18 is mild, less than 10 is moderate, less than 5 is severe. So coming to the pathophysiology, I need to spend some time on this. You need to understand it better so that you will treat the child better. So the insulin is basically produced from the pancreas. It is basically an anabolic hormone. So it will store all the energy forms into the glucose into glycogen and amino acid into the muscle and fatty acids into the store. So it's basically anabolic hormone. So whenever the excessive food state is there, the insulin will be produced almost like more than 15 times. So it will store all the food into the human body. Then later in the postprandial state, when there is a food availability from the GI system is not there, so the insulin will come down. Slowly the counter-regulatory hormones will increase. Okay, so can you name some counter-regulatory hormones? Very good. So glucagon is one of the counter-regulatory hormones. So glucagon, adrenaline, noradrenaline, cortisol, growth hormone, thyroid hormone, all these are the counter-regulatory hormones. So always there will be a balance between the anabolic hormones and the catabolic hormones. So to maintain the glucose levels within the normal state, like in the fasting state between 70 to 100, the postprandial state it should not cross more than 140. So there is always a balance between these anabolic things and the counter-regulatory hormones. So what happens in DKA? So there is a insulin deficiency. So because of the insulin deficiency, there is an imbalance between the anabolic hormones and the counter-regulatory hormones. So what does counter-regulatory hormones do? They actually promote the opposite to the anabolic hormone. So they will break down all the proteins, fats, and glycogen. So they will try to promote more and more glucose formation. But already glucose there in the blood, but it is not able to utilize by the tissues because of the lack of insulin. Okay. So this important counter-regulatory hormone is the glucagon. So the ratio of insulin and glucagon is very important to have a proper effect on the metabolism through maintenance of the glucose within the normal limits. So why we need glucose? So mainly for the brain function. So almost 20 to 30% of all energy will go to the brain only. So there should not be any low sugars, there should not be any high sugars. So that's how it's tightly controlled. So whenever there is a glucagon, what it happens is the malonyl CoA, so that is one of the important enzyme, substrate in the Krebs cycle. So insulin will promote the increased level of the malonyl CoA, so which will suppress the keto, that is lipid oxidation. It will suppress free fatty acid oxidation. It will suppress. But whenever the glucagon is high, insulin is less, this malonyl-CoA levels are less. So that indicates body is actually going into the low glucose status. If there is a high glucose will enter the cell, glycolysis, then Krebs cycle, high malonyl-CoA. High malonyl-CoA will block the acylcarnitine pathway, so that free fatty acid won't go into the mitochondria for proper oxidation of the free fatty acids. But when there is a deficiency of insulin and increase in the glucagon, so this pathway will reverse and more free fatty acid will be taken up into the mitochondria. So there will be free fatty acid oxidation, more ketosis formation. So free fatty acids, from where they will come? They will come to the fat. Okay, so the fat will contain triglycerides. So they will give 3 fatty acids and 1 glycerol. So glycerol will be converted to the glucose. Again, it will be added to the more and more glucose, but it cannot be utilized by the tissues. Fatty acids will go into the fatty acid oxidation, more and more byproduct of the keto acids will be there. So that is what happens when there is a misbalance between the counter-regulatory hormones and the enzymes. So because of this hyperglycemia, the patient will be having symptoms like polyuria, dehydration, and because of the ketosis, there will be rapid breathing, Kussmaul's breathing, and other decrease in conscious level, abdominal pain because of this acidosis. The symptoms of DKA are from these two. And once we made the diagnosis of DKA through that diabetes, ketosis, and acidosis, they should have all the 3 should be there to call it as a DKA. If ketosis is 1 place and sugars are more than 200 and acidosis is less than 7.3, we may not call it as a DKA because other conditions like infections where lactic acid will be elevated, so they may be contributing towards the DKA. So initial assessment, so you will be well versed with these protocols like PALS, NALS, whatever it is. So those protocols will be utilized. So initial assessment of circulation, airway, breathing, then hydration state and heart status, everything you need to take care. And initial blood workup we need to do. So basically the required for the blood glucose levels, electrolytes and creatinine and ABG levels, and to look for the other parameters like electrolytes. Okay, so these are routine tests you need to do, and we need to also assess the conscious level of the patient. That is very important. So why I will be discussing later. And this Glasgow coma scale. So most of the diabetes, they will present with severe dehydration, but not as a serious condition. So most of the mortality is due to the treatment of the DKA, not because of the condition per se. So that's why you need to be very careful in treating the children with the DKA. So I will tell why. So first and foremost important is the fluid management. So once you cannulate the child with 2 IV cannulas, then you need to take care of the dehydration. So that dehydration, fluid of choices, usually when the child comes to the emergency room, you need to give a bolus. The bolus is anywhere from 10 to 20 ml per kg. Okay, so initial bolus when I was in PG, so I used to give around roughly 15 ml per kg, and the child is not in shock. So that we used to give in over 1 hour. Now we can give it over the 20 to 30 minutes. Okay, and the child is having dehydration. But if the child is come with the shock, you need to give the bolus as per the shock protocol. That is 20 ml per kg over 15 minutes. Okay. And you continue reassesses. Once the child recovers from the shock, then you start correcting the dehydration. So this dehydration fluid is separate from the shock therapy. Okay. So first shock therapy, you control it. Most of the patients, they will come with the dehydration only, not the hypovolemic shock. So then you treat the dehydration part. Okay, so this dehydration, whatever happened, we need to treat with the over next to 48 hours. Okay, but here you need to individualize the patients. Okay, because some patients who are from Hyderabad, so So with the little symptoms, polyuria, polydipsia. So they may come with a mild acidosis like pH of 7.25, bicarbonate of 18, okay, and GRBS of more than 200. The child looks stable only because there is no much acidosis. So in this scenario, mild dehydration, that is 5% of the body weight. So that can be corrected within the next 24 hours. Okay, just to add to the maintenance fluid, whatever the correction required, you can correct it. Once the child is actively taking orally, so you can give orally, subtract that from the dehydration deficient, which need to be given over the next 24 hours. And another scenario where a child comes from the far away after a very late diagnosis, they come with a very severe DKAs. In those scenarios, you need to correct the dehydration over the 48 to 72 hours, depending on the child's status. Okay. So this is the study published in 2018 in NEGM. Based on this, you need to utilize the fluid therapy in patients with the DKA. And also the choice of fluid, that is also depends on the sodium level most of the time. And that is also, that trial they have tried various solutions like half NS, NS and other solution. The outcome doesn't differ actually much. So the fluid of choice is not a big role in terms of the dehydration correction. So only thing, when you are giving a large boluses, there is a chance for the hyperchloremic metabolic acidosis, which you need not worry much. But only thing, you will see the acidosis in the ABG, but the child is recovering actually. So that means you need not worry, it's a very benign condition. And you can just ignore the condition, it will slowly goes back. So initial fluid better to be always 0.9% NS as a bolus. So this bolus should be subtracted from the deficient of the fluid. So what is the deficient calculations? Mostly 5% dehydration is mild, so 7% moderate, 10% of the body weight is the severe deficiency. So based on that, you need to calculate. For example, if a 10 kg child is there, it comes with a moderate dehydration. That means he is having a 7% of the weight loss. That means 700 ml of fluid is deficient. And what is the regular maintenance fluid for the child? So usually 100 ml per hour for the first 10 kgs, right? So it's a 1 liter per 1 day. But 2 days, it is 2 liters, okay? So these 2 liters will be adding that dehydration of 700 ml, but subtract that initial fluid bolus. Okay, if you roughly take around 15 ml per kg, you remove that 150 ml from 700, so that makes up to 550. So 2 days of maintenance is 2 liters with the addition of the 550 dehydration amount, which needs to be given over the next 48 hours for a general protocol. But based on the child's condition, you can correct the dehydration over the next 24 hours. In very severe cases, you can correct it over next 72 hours. Why we should not correct rapidly? Yes, so that is the most common cause of mortality in DKA because of the treatment. So DKA per se, the mortality is very less. Unless the child is having very fungal infection, fungal sepsis, any renal failure, severe renal failure. So usually that should not be a scenario. So what happens in the chronic dehydration and dyslipidemia, hyperglycemia? The blood osmolarity will go up, but the same level of osmolarity to do the brain cannot deal with. So it will produce some idioosmoles, so unknown osmolarity to match with the blood osmolarity. So if you rapidly correct the osmolarity of the blood, so brain cannot rapidly act on. Okay, so that's why there will be mismatch. So there will be hyperosmolar status in the brain, hypoosmolarity status in the brain. So more and more fluid goes into the brain. So that will cause the cerebral edema. That's why you need to correct the sugars and dehydration very slowly. So that is why your sugar should never be a target of the DKA treatment. Okay, I'll be discussing that also. And coming to the next part is the electrolyte management. So most important electrolyte lost in the DKA is the potassium and phosphorus. So there is no body defense mechanism for the potassium and phosphorus. They're flow dependent excretors. higher the urinary flow, there will be always loss of potassium and phosphorus. Other ions can be saved by other mechanisms, feedback mechanisms and hormones, but these doesn't have any mechanisms to protect. So the patient will be losing almost somewhere roughly between 3 to 6 millimoles per kg of potassium during the dehydration part of the DKA. So at the first initial blood sample itself, we need to check the potassium. Okay. So after giving a bolus, you need to wait. Let the potassium report comes. So if the potassium is high, so why the potassium will be high if you lost in the urine? As I discussed, potassium is the least bothered ion in the blood. So what happens in acidosis, there will be very high acidosis H plus ions in the blood. Okay. So to reduce the acidosis in the blood, the potassium will comes out of the cell and H plus ion will goes into the cell so that the acidosis part will be naturally balanced by the natural mechanisms. So that's why there will be a lot of potassium from the cell will come into the blood circulation, which will be lost in the urine. So at some point there could be hyperkalemia also. So you need to detect that. If hyperkalemia is there, you can straight away start without any potassium adding to the fluid. Even though patient is potassium deficient, but still there could be possibility of hyperkalemia. If it is more than 5.5, don't add any potassium to the correction fluids. And if potassium is between 3.5 to 5.5, then you can add a regular maintenance potassium to the maintenance fluids. So roughly it will comes to 40 milliequivalents per liter. So that fluids, in the initial first potassium is, if the patient is so much depleted, it could present as a hypokalemia also. So if the potassium is less than 3.5, you first correct the potassium, don't give the insulin. Okay? So because if you give the insulin, there is a further, again the chance of hypokalemia will be there. So first you correct the potassium with 20 to 40 milliequivalents within the next half an hour. Then once the potassium normalizes, you add potassium to the maintenance fluids, then start the insulin infusion. Otherwise the patient will go into hypokalemia. So the potassium management is very important. So once you get the samples, give the bolus of the next 20 to 30 minutes, check the potassium, then go with the next plan of action. Like potassium correction if needed, or just maintenance fluids with potassium and IV insulin, or just IV insulin without any potassium in the maintenance fluids. That depends on the level of potassium. Okay. And phosphorus is one of the other ion which will, as the polyuria progresses, there will be loss. But phosphorus deficiency symptoms are very mild and mostly unnoticeable. And most foods will be abundant in potassium and phosphorus. So you need not give much phosphorus collection unless the phosphorus level is less than 1 millimole. Okay, so this is what I was discussing. Individualization of the fluid therapy. So based on the amount of dehydration and based on the maintenance fluid correction, you want to do it over 24 hours or you want to do it in the 48 hours. Any clear? Any doubts in the fluid management? Now comes the second important thing, insulin management. Okay, so first initial fluid itself, because in dehydration what happens, there is a lot of antidiuretic hormone response. So high antidiuretic hormone, so this will actually increases the cortisol level in the blood due to the feedback mechanisms in the brain. So that itself, the cortisol itself will increase the more ketosis and more hyperglycemia. So once you correct the initial 1 hour fluids, most of the glucose will fall down and most of the ketosis also somewhat it will starts correcting. So there is no urgency for the insulin to start and wait for the potassium to start the insulin. Okay. So after 30 minutes to 1 hour, you start on insulin therapy. So that will be 0.05 to 0.1 units per kg. So depends on the amount of acidosis. If there is a high acidosis, that means pH less than 7.1, then you can start with the 0.1. The pH is somewhat near to the normal, you can go with the smaller dose of the insulins. Okay, so ideally insulin infusion should be given as a pump, insulin infusion pumps. So most of the time what happens, whatever we give through bottles and IV sets, they may not give a proper accurate going to the patient. Sometimes there will be delayed therapies and sometimes hypoglycemia risk, so that will be happen. So always use the insulin infusion pump for a better management. So what is the end, when, till what time you want to continue IV insulin? So there are the two end points. So one is the return of appetite and second is the resolution of the ketosis. Okay. There never be a target of glucose normalization in the DKA management, that you need to understand. The aim of insulin therapy is to suppress the ketosis, not to correct the glycemia. Okay. So as long as acidosis is there, you need to continue IV insulin. But if the sugars are falling very low, so somewhere around the point of 250, 300, you need to start adding dextrose so that you can push more and more insulin so that you can suppress the lipolysis and ketosis. Okay? So that is the very important point in management. So never target the glucose. You push much glucose as much possible, you push much insulin as much possible, so that your aim is to suppress the ketosis, not to correct the glycemia. And you need to monitor if blood ketones is available every second hourly and ABG every 6th hourly as per the institutional protocols. And always try to prevent the hypoglycemia. That is also one of the important predictor for the cerebral edema. Okay. And if required, you can go up to 10% dextrose also, add to the maintenance fluids, but never try to reduce the insulin infusion to less than 0.05 units per kg per hour. And one of the other thing is the acidosis management. To correct the acidosis, most of the part will be taken care by dehydration correction, and insulin itself will reduce the ketosis and acidosis part. So you need not require any specific agent to correct the acidosis. And especially if the child is having any serious depression or myocardial contractility is less and pH less than 6.9, where there is a high cardiac mortality will be high. So then only you can give the soda bicarbonate alkali therapy to the DKA patients. Why? Because actually if you are trying to treat the acidosis in the blood, so there is a worsening of acidosis in the tissue level as well as in the brain. So soda bicarbonate is as a high osmolar agent, so it can worsen the osmolarity, one thing. And the second thing, it can worsen the hypernatremia because of the high sodium content. And third thing, it will suppress the respiratory center. So it will, the movements will slow down and acidity and the CO2 flush out will be slow down and acidosis will actually increases. Fourth point, after giving soda bicarbonate, what happens? So it will be broken down the SCO3 and sodium. This SCO3 with acid, it will form the H2O and CO2. Okay, so ultimately it will produce the CO2. This alkali, whatever the HCO3 minus, that won't cross the blood-brain barrier so easily. But whatever the formed CO2, that can easily cross the blood-brain barrier. So this CO2 will go to the brain, so which will make worsening of the acidosis. It will again form the carbonic acid in the brain. So it will actually worsen the paradoxical CNS acidosis. Okay. So another fifth point is one oxyhemoglobin dissociation curve. Acidosis will actually shift the curves towards the right. But when you give acute alkali therapy, it will worsen the oxygenation at the tissues also. So these are the various reasons. That's why you need to avoid the soda bicarbonate therapy unless it's definitely an emergency. And monitoring, so you are the experts in monitoring, input and output and glucose monitoring, ketones monitoring, BP, maybe CNS, plasma, coma scale monitoring. Some of the caveats are, usually there will be pseudo hyponatremia because of the hyperglycemia. So you all know the correction, right? So how to correct the sodium levels according to the GRVS level. So once the lab valve comes, you need to correct it for the amount of glycemia is present. And the lactic acidosis is one of the other important point, and even hyperchloremic metabolic acidosis. Despite that there is correction of ketosis, but still the pHs is not coming down. So you need to think of these conditions and act accordingly. So sometimes we get a call from PSAs. We are giving a good amount of insulin, but the child is not responding. Still ketosis is not improving, but estrogen is also not improving. That's mainly because of not priming the tubes. So whenever you are preparing an insulin infusion, you need to prime the tube with at least 50 cc of insulin. That whatever the solution you have prepared, so you need to flush 50 ml of that formed fluid, or that strength we have achieved. You need to prime the tube, then you start the insulin infusion. Otherwise, this insulin, if you go directly, so most of the insulin will be attached to the plastic tubes. You will be actually giving only plain NS. So that's why priming is very important. And blocked tubes. So that is also, if you use an insulin infusion pump, it will give an indicator if the fluid is not going, not moving. So it will tell you what exactly happening. And the fluid resuscitation, if the still child is having severe dehydration also, there won't be much improvement in the acidosis. In sepsis, and they need to tackle it. And other causes of the high anionic metabolic acidosis also you need to look at. And cerebral edema, so that is also one of the important factor. The child is not improving the conscious levels. So this is what I was discussing about the mixed hyperglycemic hyperosmolarity status with the DKA. So it's a very common presentation, especially in type 2 older patients, type 2 diabetes. Sometimes it can happen in children also. So here we need to balance. So more actually towards when there is a HHS component is there, you need to give more and more fluids, and you need to tackle the electrolytes properly. So mainly potassium, phosphorus, sodium. So you need to balance that along with the insulin infusion for the DKA therapy. You need to actively search for the fluid therapy also. When to shift to the subcutaneous insulins? So as I discussed, the only two things: correction of the acidosis and return of the appetite. There are the only two criteria to stop the IV insulin therapy. Then shift to the subcutaneous therapy. And when you are shifting to the subcutaneous therapy, always remember that if you are using a regular insulin, so you need to give the subcutaneous insulin first, then stop the insulin therapy. So at least 30 minutes to 1 hour before to the stopping the insulin infusion, you need to give the rapid acting, actrapid and regular insulins. Or if you are using a long acting, because you have to stop around 4 p.m., 5 p.m., the child is not eating that time, you can use a long acting. Okay, something like Glargine, Lantus. So you can time it at least 2 to 4 hours prior to the stopping of the infusion. If you stop, because insulin will take, after injection, it will take some time to act and appear in the blood. So that's why you should time early before stopping the insulin infusion therapy. There are so many complications happens before and during the treatment of DKA. So you need to be aware of all the dyselectrolytemia conditions and hypoglycemias, thrombosis, because it's a hyperosmolar state, so there is a high risk for the thrombosis, the pulmonary embolism also. So you should have a vigilant eyes. So if the child is not improving, you should take care of all these complications. I'll be mailing this PPT, no need to take photographs. So all these things you need to be carefully assess and discover as early as possible in the patients. Renal failure, acute pancreatitis. So these are also rare complications, but we should thoroughly look for them. One important complication is the cerebral edema. I want to discuss 1 or 2 slides on this. So 60 to 90% of the death in the DKA is due to this complication. And most of these complications arise during the first 12 hours of the treatments. That's why the treatment during this initial part of this very, very important. The risk factor is more dehydration, more profound acidosis, more ketosis, and any bicarbonate therapy, or IV bolus, insulin bolus. Previously there was used to the practice that first the child comes 400 sugars, give IV bolus followed by the insulin infusion. But if you give IV bolus, there will be a rapid change in the hyperosmolarity status. Glucose will suddenly fall, so that will change the dynamics and more occurrence of the cerebral edema. And IV bicarbonate therapy, so these are also causes, risk factors for the cerebral edema. And signs, you all know, the increased intracranial tension that will cause Cushing's triad and decreased oxygen saturation, decreased GCS papillary edema. And you need to do neuroimaging. So, but if the patient condition is worsening, don't wait for the imaging. You can directly go for the treatment aspect. So the treatment is, suspicion is very important. Rapidly identify the condition, then follow the, try to measures to reduce the intracranial tensions. Mannitol and hypertonic saline can be used, and if required intubation, and you slow down the dehydration correction therapy. So reduce the dehydration correction therapy to 75% or less, and head and elevation, prevent the hypoglycemia. Hypoglycemia will also trigger the cerebral edema. And right, if intubation and prevention of recurrent DKA. So this is very important aspect, because most of the recurrent DKAs occurs in 5% of the failure, the type 1 difficult to treat patients. You need to educate them on sick day guidelines. Even if the patient is sick, they should not miss their basal insulin. And based on the eating patterns, they need to give a small amounts of the bolus insulin. More and more frequent checking and more frequent checking of the blood glucose. Nowadays we have a ketone strips also, blood glucose monitoring strip. So you give to the patient. So frequent monitoring during the sick day is very, very important to prevent the future DKAs. And omission of insulin, that is also, and binge eating, some poor metabolic control. So there are the most more frequent infection risks. So there are also more frequent risk factors for the recurrent DKA. This is the protocol. What I discussed, it is here, so I will send you. Thank you. Any questions?